I'm going to welcome you all. My name is Marty Mascari. I'm with the North Central Texas Area Agency on Aging and the North Central Texas Aging and Disability Resource Center. We welcome you all today once again for our series with the James L. West Center in Fort Worth to talk about trauma-informed care. And Hollie Glover and Jamie Tinsley, I keep forgetting that you have the new name. Jamie got married recently, so Jamie's on too, and they're going to bring their expertise to us. But first, we're going to talk about the CEUs, and so the next slide will go over that. And so, Jamie, do you want to do that?
Absolutely, thanks, Marty. We are very happy to offer CEUs for nursing, social work, licensed professional counselors, and anybody that wants a certificate of attendance. You will receive a follow-up email from this webinar that will have the information about how to obtain your CE credits. You'll click a link and you'll go fill out an evaluation for the program. And then once that evaluation is complete, within about 3 weeks, you will receive your CE certificate or certificate of attendance in your email address you provide. The survey will close on April 20th. There at the end of the day on April 20th, and once it closes, we're not able to open it back up again. But do please allow us a couple to 3 weeks to get those certificates turned back out, processed and turned back out to you all. Thank you.
We're very grateful for you guys doing that. That is just a great blessing. Thank you all for doing that. That's wonderful. In addition to their survey, we also will have a survey we have to do for our funders. It should pop up via Google when you close out today. I know a lot of companies have blocks against some of those pop-ups. So if it doesn't, you'll also be receiving that link to that survey with the first follow-up email that I send out after today's webinar. And that will have all of their CEU information as well. I want to thank Ashley, is it Alicia? For putting on the link for me. I just did it, then I realized you had done it. Thank you so much for doing that. So if you want to introduce, Jamie, do you want to introduce Hollie and we'll get rolling?
I'd be happy to. Hollie is our Director of Education and Family Support Services here at the James L. West Center. She is a licensed professional counselor, dementia care expert, and a licensed grief counselor. And I think she's got several other letters behind her name as well. Very well versed in what she's talking about, particularly in trauma-informed care, which she will be talking about today. So go ahead, Hollie.
Thank you, Jamie. Appreciate it. We always enjoy being here. So we are glad to be able to bring you this program today. I know some of you are on that may have been on our Lunch and Learn last month with the West Center. We do a monthly Lunch and Learn, and we did this topic, but my slides wouldn't come up because once you think you've mastered Zoom, and then it goes and messes with you, and we couldn't get the slides to work. So we're glad to have everybody here. I'm sure we'll have some more folks join us as well. So let's get going. We will leave some time at the end for some questions. If you we cannot see or hear you because we've got so many people that are going to be on this today. We've already got over 160, so don't worry about that. But if you have questions or comments, please be putting them in the chat. Marty and Jamie will be watching those for me, and we will get to those at the end, and I will be watching my time. So let's talk about trauma-informed therapy. Most of us who work in this business have heard of person-centered care. That's one of those terms that we've heard for a long time. But we are starting to hear more and more and more about trauma-informed. So we need to go back and just go, okay, so what is trauma? Let's just look at what is trauma. And let's just look at where does this come from? So from the Center for Healthcare Strategies, let's define trauma, and then we're going to get into it. We're also going to look at how we can help our be a better place to take care of residents, clients, patients, but how we can also better take care of our staff. Because once we really kind of dig into this, we find most everybody somewhere in our life has had some type of trauma, and we can even better take care of our staff if we look at some of these tips that are on here, and I'm going to give you some good resources too at the end. Okay, so let's look at trauma. Trauma is something that results from exposure to an incident or a series of events that is emotionally disturbing or life-threatening. So Many people, when they hear that word trauma, they think of that first bullet point, physical, sexual, or emotional abuse. Of course, we're all going to think of that one. But let's look at many of these others. We have just been through 2 years. We are still going through a pandemic. We are going through a time that we haven't lived through before. We are still in what's called the messy middle. This is not a new normal yet. We are not to the new normal. This is still a messy middle. We've all been through some trauma recently because of change that we didn't ask for. So there's been some trauma just from that. But then let's look at these other types of trauma. Childhood neglect, of course, is trauma. Having a family member that has a mental health or a substance use disorder, that brings trauma. When there is violence in the community, there's trauma. We've had that. We've witnessed that. When there is a natural or a human-made disaster or forced displacement, there's trauma. That plays right into what we've been living the last couple of years. When there is a sudden or unexplained separation from a loved one, those of you who work in long-term care, assisted living, we've watched this happen. What just happened to our family members 2 years ago when we had to make those phone calls and say, we don't know when you can get back in here to see your loved one? Trauma. For them, for their loved one, and for us working in healthcare. In 2020, 31% of all suicides were healthcare workers. Trauma. And poverty and discrimination. So let's look at the prevalence of trauma. This is a study that was done by the Philadelphia Urban. It was a study done in Philadelphia. And let's look at these numbers. 83% of adults in the US have at least one, and ACE stands for Adverse Childhood Experience. And we're kind of going to deep dive into that in just a minute. 83% of adults in the United States. So what does that tell us? That most everyone has experienced some type of trauma in their life. And then look at this next one. 37% of people in the United States have had 4 or more adverse childhood experiences. And we're going to look at some specific examples of that. And with this many people on the call, we're getting close to 200 people on the call. I'm talking to a lot of you that's going to fall right into this. We're not just going to be talking about our clients, our patients, our residents. It's going to be us. And for those of us that are social workers and counselors and nurses, and that we're in the helping profession, there's a reason some of us went into this field. 1 in 4 children in the United States experience some type of abuse. These are the latest numbers. I pulled these numbers this year. So this is the 2021 numbers. 1 in 4 women has experienced domestic violence. 1 in 5 women and 1 in 71 men have experienced rape. And 12% of women and 30% of men were less than 10 years old when that rape occurred. That is trauma. So here's some examples I was talking about earlier. Trauma-informed care understands why a person turns to drug and alcohol. They're escaping. They are numbing themselves. Instead of judging it, they're understanding why they do it. More examples of trauma, and these are 10 of the most common that you'll find. I'll be curious to see how many of these in your careers you've come across, either personally or professionally. And let's look at these. And again, those of you who've been on these programs know I am not one to read slides, but this is a fairly new program that we're doing, and it's powerful. And this is a pretty new topic, and we need to really look at this. Let's look at this first one. Somebody who was as a child, survived a life-threatening illness, but then as an adult is afraid of all needles and doctor's visits, and they get extremely anxious. So let's say we work in memory care and we have a resident that anytime somebody who's in scrubs or a white coat comes around them has a challenging behavior. It's probably important that we know that information, that they had a life-threatening illness as a child. This is what trauma-informed care is about. Maybe it was before the age of 10, and now they're in their 70s, but we are triggering something from their past. We've got to know about it. A woman who's had multiple miscarriages and or failed IVF treatments, and she sobs during a routine exam. 99% of women in substance abuse programs report a history of trauma, most of it in their childhood. I've watched this happen right here at the West Center where I work, because we also are VA. A man who was in the military takes cover or hides when he hears thunder or sirens, or the fire alarm is being tested. They're taking cover. We have those challenging behaviors, and it's because of something that's going on in the environment, something that maybe we could control if we knew their story. This is one of the reasons that I focused on narrative therapy. We have to know a person's story to best be able to serve them. Men or women who don't allow people to get close to them because of the harm they've had in the past. And even if the harm didn't happen to them, but they observed physical, sexual, or emotional abuse. Childhood neglect is on there again. And here, this is on again, having that family member with a mental health or a substance abuse disorder, growing up with that alcoholic parent, experiencing and witnessing violence in the community or while serving in the military, and then poverty and systemic discrimination. So I'd mentioned that ACE. You're going to be seeing this. It'll just be written as ACE. And the more this, we're going to talk so much about trauma-informed care. You're going to be seeing it in more articles. It's already coming out in our magazines and our journals. So you'll be seeing ACE is how they abbreviate it. So it talks about adverse childhood experiences. And this is exactly what it is. A study that demonstrated that the more a child is exposed to physical, emotional, or sexual abuse, neglect, discrimination, and violence, listen to this, the greater the risk for chronic health conditions and health risk behaviors later in their life, like heart disease, depression, liver disease, sexually transmitted diseases, and substance abuse, because that trauma is affecting their health. There is a link between childhood trauma and lifelong health problems. Chronic lung and heart disease, liver disease, hepatitis and cancer, autoimmune diseases. There's the sexually transmitted diseases again, depression and other mental health conditions. So what is happening? Why is it that childhood trauma is affecting neurobiology? So think about what's happening in the brain of a child before the age of 5. Those positive experience that a very small child, a toddler has, leads to healthy brain development. But those negative experiences are promoting unhealthy brain development. When a child younger than 5, think about this. When we are in a constant level of stress and we are dumping cortisol and adrenaline all the time, what does it do to us physically? What does it start to do to our brain? What does it start to do to us physically? And our brains are already completely formed. Now imagine a toddler living in that state of fight, flight, freeze. It decreases the volume of their brain. It doesn't fully finish forming. And because of that, these children then, on that third bullet point, decrease the volume in the areas of the brain responsible for cognitive functions such as short-term memory, emotional regulation, and other higher cognitive functions. So when you really study this, there are certain populations that are more at risk for trauma. People who live in low-income communities, ethnic and racial minorities, LGBTQ individuals, individuals with disabilities, and women and girls. And then how does that trauma then affect those health risk behaviors? How do we tie this together? Because as a child, you have to learn to cope. And many times the very people you're watching to learn, how do I cope with this? You're learning a negative or a poor coping skill. But they develop coping mechanisms because they have to alleviate that hurt of trauma. They're trying to survive. And many times those coping mechanisms involve health risk. Because one of the easiest ones is food. And it's usually the most readily available. And so children will overeat and they'll watch other people overeat because they'll see that be a coping skill for a parent. They may turn to tobacco use very young because they watch an adult, and drug and alcohol use. And then tie this together. Their coping mechanism is contributing to anxiety, depression, social isolation, and chronic illness because of unhealthy foods, tobacco use, drugs, and alcohol. So you start to see this pattern. And again, working in the field, you can see where we're headed down the line. You see where we're going. So as healthcare providers, how can we help patients heal from trauma? The first thing we've got to do is we've got to recognize trauma and to understand that most everybody at some point in their life has probably experienced some type of trauma. So the first thing is we have to create a safe environment. We have to be caring. We have to be inclusive. Those are the keys for us being able to deliver effective care. Whenever we provide a workplace that is also safe, caring, and inclusive, that is going to help with staff burnout and turnover, help us avoid provider burnout and turnover. Now, as therapists, some of the things that we might use as counselors LCSW, some LMSW. Some of you may use prolonged exposure therapy, EMDR, and there's lots of different types of therapy that you may be able to use with clients. So let's look specifically at what is trauma-informed care. And I've given you a website here that you can go to, traumainformedcare.chcs.org. And again, you are getting these slides. If you haven't got it, I think they've put it in the chat, but you'll also get it in the follow-up email. This first bullet point is the most important bullet point, I think, in the entire program. We as healthcare providers have to shift from what's wrong with you to what happened to you, regardless of what field we work in. I happen to work in dementia care. And I have to look at every one of my residents, not with what's wrong with you or what type of dementia do you have, but what happened to you? What happened earlier in your life that may be the reason you're having these challenging behaviors today with this type of dementia that you have? Got another story. That's why we have to have that complete picture of a patient's life. That's what trauma-informed care is all about. Their past and their present. Then what we have to do as providers is have an open mind and be compassionate. And we're in the wrong field if we don't have compassion. All of our patients, clients, residents deserve it because everybody has a history. Everybody does. You have one, I have one, we all have them. They don't look the same. And we saw those numbers of over 80% of the people with histories of those ACE, those adverse childhood exposures, physical, sexual, emotional abuse, or serious illness. And if we can meet them there, there is research that shows it's proven to improve a patient's engagement. We're allowing them to talk about it. Their treatment adherence and the outcomes of the treatment, and then staff wellness when we address things with our staff. And keep in mind, we don't always have to be the one trying to fix it. Sometimes we're just having to be the one to hear it. There are things that can't be fixed, but it needs to be heard, because a lot of people are carrying things that they've never even been able to say. And those of you who work in therapy know we've got our thing that we say, if you can name it, you can tame it. If you can just say the words, if you can help somebody say the words and get it out or write it down, and they can start to move forward through their pain, through their trauma, if we can just help them say the words. So there are 6 goals of trauma-informed care. Let's look at those 6 goals. Actually, I think my numbers are off. I think there's 7 goals of trauma-informed care. So trauma-informed care. And they are listed here for you, and I'm not going to read through every one of those. I want to point out a couple of them. We want to make sure that we actively avoid re-traumatization, and we're going to talk about that. Integrate knowledge about trauma into our policies, procedures, and practices. Let me go to this next one. And yes, my numbers were off a little bit. Collaboration, so that power difference between staff and clients and among organizational staff are leveled to support shared decision making. This is where our client, our resident, our patient gets to be part of the decision making. Then they have some ownership. I feel like you heard me because you're letting me make decisions about my own care. You're listening to me. You're not just telling me what to do. This is trauma-informed care. Because what does that bring? empowerment. We build on their strengths. We validate them. And what does that then do? It includes that belief in resilience and that ability to heal from trauma. We can push through. We can go back and we can talk about, this talks on number 6 there, shows historical trauma. It's recognized and it is addressed. So here's the benefits of trauma-informed care. There's a couple of benefits. It's going to be listed here, one for patients, one for staff. And again, because there's a large group of people on, some of us call clients, patients, residents, regard of whatever field it is you work in. So for patients, it offers the opportunity to engage more fully in their own health care. They feel like they own it. They have a say. It develops a trusting relationship with their provider, and then it improves long-term health outcomes. It's been shown over and over and over again. And then for staff, it has been shown to reduce burnout. So let's look at the principles of trauma-informed care. These are the 6 principles with trauma-informed care. And number 1, I mentioned it earlier, is always safety. Our patients, residents, clients, and our staff have to feel physically and psychologically safe. We're going to look at some ways to do that. But the very first thing is we have to feel safe. If a person doesn't feel safe, we know what they're going to do. Some of you do it. I do it. If I'm not safe, what are we going to do? I'm aware. Look out. Dumping that cortisol. I am most definitely not giving you my full attention. And I'm not going to share everything with you that maybe I need to be sharing with you because I don't feel safe in this environment, or I don't feel like you're giving me your full attention right now anyway, because you don't seem to be understanding, or maybe you seem judgmental. That feeds right into the next one, from safety to trustworthiness and transparency. Peer support. Individuals with shared experiences are integrated into an organization and viewed as an integral to service delivery. This is where we come together, and we've got to be able to know signs and symptoms of trauma exposure on physical and mental health as professionals. It made me going back and taking some CEUs, doing some refresher courses, promoting that patient-centered, evidence-based care. This is not getting away from person-centered care at all. This is another layer to person-centered care. And then providing care that's sensitive to a person's racial, ethnic, cultural background, and gender identity. This is kind of an organizational chart, the key ingredients for trauma-informed care. And this is from CHCS, the Center for Healthcare Strategies. And so it has organizational and clinical broken down there. And we are going to take a few of those and kind of look at them a little bit deeper about how to do those. So this is the chart, and we're going to take several of those and look at them a little closer. And the first one is implementing a comprehensive trauma-informed approach. We've discussed empowerment, using that individual's strengths to empower them, allowing them to make choices, using that collaboration. There's safety again. Safety is going to come up over and over, and so will trustworthiness come up over and over. So where do we begin? The first place we have to start is to build awareness and generate buy-in from a trauma-informed approach to care. So support a culture of staff wellness. This is one of the ways that we can start if we're trying to bring this in where we work. Trauma-informed care, we've got to support a culture of staff wellness. Hire a workforce that embodies the value of trauma-informed care and create a safe physical, social, and emotional environment. How do we go about doing that? So we're going to look at the first one. And again, because of time and because I want to leave time for questions, there's a lot on these slides. I'm going to hit the highlights, and you're getting these slides. It's been put in the chat, but we're going to talk about the highlights on these. We want to make sure to build awareness and generate buy-in for a trauma-informed approach to care. So the first thing we do is communicate to staff the value of trauma-informed care and its potential for improving resident outcomes and staff well-being. So we approach it from both sides, how this is so good for our residents, but how great it is for all of us as well. Promote the potential to improve patient outcomes as well as staff wellness. Incorporating the patient voice and choice, it's one of the ways that it can be worded. Offering trainings for all staff on trauma and its impact on health and behavior. Then we're going to identify champions and leaders to help build awareness about trauma, to be the ones to keep pushing forward with this, and incorporate that trauma training into regularly scheduled staff meetings. This isn't going to be something that we just get everybody trained and then we check that off the list, but that's what those champions are going to do. It's going to keep it at the forefront of everyone's mind. They're going to be the ones that continue to do training, continue to keep up with the research. Supporting a culture of staff wellness. So this again, educate staff on secondary traumatic stress, vicarious trauma, burnout, and self-care. This is where we are going to promote PTO time for mental health days. We're going to promote a work-life balance, and we're going to show our staff how to do it. We might even incorporate staff wellness activities, like 3 to 5 minutes of deep breathing at staff meetings, or at shift change, or stretches during lunch break, or making people take lunch away from their desk. Promoting in-house and external opportunities to foster staff wellness, like yoga or meditation. Hiring a workforce that embodies the values of trauma-informed care. And if you're already doing some of these in your workplace, I'd love for you to put them in. I worked someplace one time that at 3 o'clock every day, regardless of what you were doing, everybody stopped and got up and walked. Everybody stopped and got up and took a walk. You could continue your meeting, but you were going to meet while you were walking. So that's one of those things. So hiring a workforce that embodies the values of trauma-informed care. So include interviewers from a variety of cultural and racial backgrounds, as well as different levels within the organization during the interview process. We tend to use the same people over and over and over and over whenever we interview, and we're using the same questions over and over again. Ask the potential new hires about their knowledge around trauma and about those ACEs and whether they've received any training. You can ask people that if they've had any training in trauma-informed care. And creating a safe physical, social, and emotional environment. This is big. People with histories of trauma often feel unsafe in unfamiliar environments, which leads to anxiety and stress. So minor changes can help improve the feelings of safety, and minor changes can help reduce an occurrence of re-traumatization. This is a really big one right here, this very first one. And I have this on here because this happened to me. It's happened to me this year. Make sure all parking lots, common areas, bathrooms, entrances, and exits are well lit, especially important after dark and on weekends when there might not be as many people around. If you're somebody who has trauma in your past, as I do, you do not want to walk through a dark parking lot. And if I have to walk through a dark parking lot on my way in the building, I am coming in to work and I'm already anxious or upset or on edge. And now I'm going to sit down and do my job. Or I'm going to go on the floor and help other people because the lights are out in the parking lot. Those are easy fixes that we need to stay on top of. And we need to have an environment where we feel safe enough to go in and say, Hey, did you know the lights are out in the parking lot? I'd really appreciate if somebody could get those fixed. And I did that. I'm not comfortable walking through that dark parking lot. It really might not bother some people, but it really bothers me. And we need to feel safe enough to say that without being judged for it. Keeping noise levels as low as we can, avoiding overhead speakers. People who have trauma in their past, that's a startle. That causes a startle reflex. Some of you on this call today know exactly what I'm talking about. Another thing we want to do is create a safe social and emotional environment so that the very first, whatever we see when we walk in the door is welcoming. We don't want to walk into a sign that says no cell phone use in the lobby. But if it said, please refrain from using your cell phone in the lobby, that's a little bit different, but saying the same thing. We train that front desk staff to greet patients and staff in a welcoming manner. How to talk to families, how to talk to residents and to each other. That's creating that safe social and emotional environment. Teaching about interpersonal boundaries and managing conflict appropriately. We've got to make sure that we're addressing these at orientation. Hopefully before our staff gets on the floor. I know lots of times we've got to get them to work before we even get them through orientation, but it'd be great if we could get this in place before they hit the floor. Keeping consistent schedules and procedures so that people aren't taken by surprise, because people who have trauma in their past don't do well with change, or they need to be notified of change. They don't need to have it kind of sprung on them. And then making sure that when we do have communication, that it's consistent, it's open, it's respectful, and it's compassionate. Being aware of how an individual's culture affects how they perceive trauma, safety, and privacy. The other thing we want to do is anticipate emotional responses and avoid re-traumatization. That is the last thing we want to do, because a person who has those ACEs, the adverse childhood experiences, may feel shame, blame, anger, sadness, and embarrassment. They may not even know they're carrying that. We have to approach others with that non-judgmental support. Play on their strengths. Recognize and integrate their strengths. Provide that supportive, compassionate response into trauma histories without eliciting specific details. We don't need too much too soon. And avoid creating an environment that inadvertently reminds them of their traumatic experiences. But we want to empower them by providing education on things they can do every day to recognize how stress shows up in their bodies and help them regulate their stress response and buffer the negative impacts of their toxic stress. So what we can do to prevent secondary traumatic stress in our staff. Providing training is the first thing that raises awareness of secondary traumatic stress. If we can do it in person, that's always so much better than putting them in front of the computer. I know that it's easier to put people in front of the computer, but how many times when we put them in front of the computer, are they sitting there going click, 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 click while they're looking at their phone? If we can do some in-person trainings, and we're starting to open back up to in-person trainings. Offer opportunities to staff to explore their own trauma histories by bringing in somebody who's trained in trauma. Have some support groups. Offer, maybe through your work, you offer some counseling services. You're going to end up with a better employee. And then encouraging that physical activity, yoga, meditation, and again, allowing for those mental health days. Here's another resource for you. If you go to bettercareplaybook.org, this is going to have some great information for you as well. bettercareplaybook.org. And it's going to kind of walk you through how to do this. Adopting a trauma-informed approach to care takes time to implement, and there is no one-size-fits-all approach. So taking the time necessary to ensure a strategic approach tailored for your population and setting, and you may have to try a couple of different times and a couple of different ways. But early in the planning process, I mentioned this earlier, identifying some champions, those trauma-informed care champions. They're going to generate the interest, and these are the people in your organization that are going to sustain the momentum. Then we're going to establish the talking points for making the case to leadership, because we got to have the buy-in from leadership. And many times it's going to be our non-clinical staff. It's going to be the front desk. It's going to be a dietary, because they're the ones who may be interacting with the residents. And they're the ones who make our residents feel safe. So it's important to include them in all trainings. And who sees our families first? Our front desk staff. Our families need to feel safe because they have trauma too. And then gaining that buy-in from senior leadership. They must encourage all staff to participate in trainings, promote staff wellness through policy and practice, and then other organizational changes that may happen. So I've got some good resources on here for you. I've put them all on this one page, so you'll have it there. I've also got some other websites that you can look at. I wanted to make sure and leave time for questions, or again, I had asked if you have implemented some of this already. You may not have even known that you were doing it. I wanted you to share that, and I see there's several things in the chat. This is my information here at the West Center. If you ever would like to just talk about something, you can reach out to me, or if you need a program done, we love doing these programs, or if you need to talk through getting some trauma-informed care set up at your place of business. So let me stop sharing so I can see a little better and see the chat.
Deborah has a question. I saw that. Just want to make sure you're.
Yeah, hold on just a minute. I see several.
Great.
Differences in codependency treatment cycles back in the 90s, trauma necessities, some form of emotional shutdown. Yes. Yeah.
I know a lot of it's comments.
Yes, yes, yes. Yeah, because we're seeing this. We haven't always just been calling it this, but yes, Patricia said trauma necessitates some form of emotional shutdown. And I think that we're finally just seeing we have to address this. We have to. What happened to you? Yes, not what's wrong with you, what happened to you, and saying it with compassion. Website says, okay, there's another resource that was put on. Good, good. A book with exercises and easy to grasp treatment plans. Thank you for sharing that. Evidence-based care, so you can provide some examples from your perspective. Okay, somebody had asked for an example. So when we know we're going to have to do a fire drill, because we do have a lot of veterans here, we can actually go and tell our veterans that we are going to, that we are in our safe place and that we're going to shelter in place, that it is time to shelter in place, because we have to test the fire alarms. That's one thing we've done. We are getting ready to shelter in place because the alarms are about to go off, and we're going to shelter with them. We're going to shelter in place right now because we know it's going to be over in just a couple of minutes, and we all shelter. We're sheltering in place. Then we've done something completely opposite of that. I had to do this in the day program. I had a gentleman that when the fire alarms were going off, he started trying to remove people from the building because that's what he was doing. He was removing everyone from the building. So we actually did a drum circle, and we started beating the drums to the beat of the fire alarm. So as the fire alarm was nah, 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 we were beating the drums to the beat of the fire alarm. It worked so well. So just a couple of, where we are going to their world. Now, this is memory care, this is dementia care, and both of those worked really well. Are there places to learn more? I'll tell you what, there are places to learn more. I have been doing some workshops. I found one through TAPS, T-A-P-S. There's getting to be more and more workshops out there right now. I am looking for some certifications, but I haven't done anything yet. But I do think that we're going to be seeing more and more about this. That's why we decided to go ahead and write this program to just kind of start. Let's just do some touch points on it. Show staff how to do it. Yes, that's key. Show them how to do it. That is why we added it to our orientation about how to talk to each other. We start our orientation with a video on empathy. That's the way we start our orientation. It's a 4-minute video on empathy in healthcare. I think is the name of it. It's on YouTube, Empathy in Healthcare. And it is everybody has a story and everybody has life going on. And we all just collectively have come through some trauma and are still going through it. And that's on top of the rest of our life. And then when we come here, we've got to focus on these 100 people all day long today. So yes, showing them how.
Couple of things. Nikki, I saw that you raised your hand. I don't know if you have a question, but if you do, if you could put it in the chat or the Q&A, that would be helpful. We've got a lot of people and it's just hard to call on individuals and open up mics when you got so many people. The other thing real quick is for those of you that are on by telephone, if you would please send me an email with your telephone number and your name so I can make sure that I link you up in our attendance. That would be great. I saw there's several people on by phone.
Okay. Deborah had asked, do you see trauma-informed care as the opposite of prolonged exposure treatment? No, because prolonged exposure treatment is actually one of the tools that is recommended to use with trauma-informed care. It is just knowing when to start it, when to use it, and making sure to not re-traumatize. So it is a tool that is used in trauma-informed care. Yes. Let's see, very helpful. Thank you. Thank you for all the great comments. How do you talk to seniors about getting counseling? It is hard to hear. I know that. I understand it is. So with most of, like our residents here, I'm not a counselor because nobody wants to talk to a counselor. In fact, I'm going up to talk with somebody as soon as we're finished here. I'm somebody's friend with lots of people, especially if they're placed. I will show up without my name tag on, and I will go up with someone else and say, I am such and such's friend. It is so great to meet you. And I'll go in and just start visiting with them. And within a very few minutes, we're having a session. I used to have support groups with people who had dementia, and I called it Chit Chat with Hollie. We put it on the calendar as Chit Chat with Hollie. Come and talk with Hollie today. And we were having a full-blown support group, but we never called it that. But getting seniors who don't have dementia to go to counseling can be tricky because it's got a stigma. I don't need any help. If you can encourage them, if they're members of a church, sometimes going about it that way and saying maybe doing pastoral counseling or visiting with a member of the clergy, they might go about doing that. Or if you use the word education, if you don't necessarily call it counseling, maybe just going and learning a little bit more about, you don't even use that word counseling. For some reason, counseling and therapy is a very scary word. Entire hospital system. International resources. I'm in Canada. Trauma. Oh, thank you for sharing that international resource. I am not aware of any other international resources. I sure can look into it though. I would be happy to look into that. Experience trauma through the home life. lifelong process. That's right. It doesn't just go away. And then we can be trauma-informed touch therapy can be very helpful too. Thank you for sharing that. We can be triggered sometimes and we don't even realize what it was. Will training be offered again? This one was recorded. Yeah,
yeah.
Mark.
Just so you know, we record all of these, and you will receive the link to the recording in the second follow-up email, which will be about a week from now. But you'll receive a first follow-up email today with the CEU information, but the second one will have the link to the recording.
Increase in ADHD. Yes, yes. I am glad you shared that. Read the book CPT SD From Surviving to Thriving by Pete Walker. Cindy, thank you for sharing that resource as well. Do you see increasing number of ADHD in the elderly? Yeah, because that was something we didn't talk about before. That is fairly new in the big scheme of, now it seems, people will say, oh, everybody gets diagnosed. Well, it's always been around. We just didn't call it what it is. Just like we didn't used to use the word Alzheimer's or the word dementia. We said people were senile or they had hardening of the arteries. Now we're calling it what it is. So yes, absolutely. I see it in seniors that there's ADHD, but we weren't calling it that. Absolutely right. Good call. Any books about transitioning to nursing care for elderly and their caregivers? There are some good books. If you will go on the Alzheimer's Association website, alz.org, and I cannot recall right off the top of my head, but they've got resources about transitioning, about how to talk to families, about how to talk to people who are needing to transition. If you can email, you can even email me and I'll find those for you, Deborah. So my email's on that last slide, and then I'll also type it in. I'm hglover@jameslwest.org.
And then if I could get you to put up the slides one more time, we want to go over the CEU stuff again, and then we have another webinar coming tomorrow that I put at the end. We're working on the topics for next month. We'll have them very quickly, and I'll send them out.
Back to the CEU.
Yes, if we go to the second CEU, and then, which is, yeah.
Got it.
That's great. Jamie, I don't know if Jamie is obviously not on
Yeah,
still.
she has to go to another one.
I'll go over the CEU stuff with you. For those of you that are on looking for CEUs, there's CEUs available for licensed nurses, social workers, LPCs, and certified attendants. You must complete the entire webinar. You must complete the SurveyMonkey evaluation form. The link to that will be sent out in the first follow-up email that will actually go out tomorrow morning. That SurveyMonkey will be available to you until the 20th of this month. It will close at the 20th and it won't be reopened. It will close out. So you need to do it before the 20th. That's one of the requirements. And then your CEUs, it will take about 2 or 3 weeks to get those out to you, the certificates. Additionally, for our funding sources, we have another evaluation that should pop up as you're logging out today. And if it doesn't pop up, there'll be a link for that also in the first follow-up email that will go out tomorrow. Once again, the second follow-up email will have the recording in it, and that will go out about a week from now, and that will be a link to the recording of this on YouTube. And then I'm just going to plug one we have tomorrow. If you go to the next slide, we've got and a lot of this kind of goes with some of the stuff that we're talking about today, but tomorrow is
the next.
One more slide, no?
You just added those two.
Oh, wow. Okay. I thought there was one at the end. Okay. So tomorrow is mental health and the psychological burden of pandemic, war, aging, decline. Aging and decline in health. And that will be, I'll have a link for that in the follow-up email as well, if you're interested in tomorrow's. And as soon as we have the topics for next month, I will get those flyers out to you as well.
Oh, there it is. Sorry.
No problem. It's great. No problem. And Hollie, once again, thank you so very, very much. Outstanding presentation, great information, very different topic than I've heard before, so it's great information. Very, very good. Thank you all. I'm sorry.
Thank you. And if anybody has any other questions, like I said, I just put my email in there, and or if you just want to visit about this, or if you've got questions, send me an email. My phone number's on there. It's easier to get me by email. But if I don't get back with you, you might have got caught up in my filter. Holler at me by phone.
Great. Hollie, once again, thank you so much. You guys, thank you all for joining us once again. I hope the information helps you or helps somebody you're helping, and look forward to seeing you on the next one.
Thank you.
Thank you and have a great day.
Bye.
Bye-bye.